another the same with monarchy. Pero dito, super marky.
Yay! Bye!
Good day, everyone. Good day, madam. This very special day as today marks our very first online discussion in NCM 107. We are the Group 1, and we will be presenting you the nursing role in reproductive and sexual health. But before we proceed to our discussion, let us first ask for the presence of the Lord. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Lord, thank you for this day, for the presence of everyone in this call. For once again, we are gathered and given the opportunity to appreciate life and your words. Forgive us for our shortcomings and cleanse our hearts as we learn and live your words and example. Father, bless our endeavors, especially today's meeting. May you guide us in our discussions, and may you enlighten our minds in every decision that we make. Give us your grace that we may effectively do our parts for your greater glory. All this we ask in Jesus' name. Amen.
Sexuality is a facet of rehabilitation that does not always receive attention. If a person can accomplish activities of daily living, such as eating, elimination, and mobility, then he or she is considered to be leading a normal or near normal life. But today, we will learn that establishing a satisfying sexual relationship and having knowledge about reproductive and sexual health is an important part of living. And now, let us all meet the reporters for today.
I am Sebastian Ticaon.
Dean B. Agora.
Hi guys, I'm Bianca Monique Viring.
Hi, I'm Madeline Cooper.
Hi guys, I am Johanna Rose C. Benitez.
Hi guys, my name po is Mary J. P. Pedilio.
Hi guys, I'm Hi guys, this is Chloe Francis.
Hello po, I'm Leslie Joy Tiros Julio.
Hi, my name is Eliza May Owen Sinaret.
So now that you've already met us, the reporters, here are some of the house rules. So number 1 is mute your microphone by tapping the microphone icon and make sure that your video is available upon the request by the subject professor. Number 2 is wear appropriate clothes or attire. Avoid wearing sando or sleeveless shirt and sleepwear. Number 3 is eating foods and playing online games are not allowed, especially when the session is running. So number 4, listen carefully and focus your attention to the reporters and the professor. Number 5 is to keep yourself away from any distractions. Number 6, please do take down notes. So now let's proceed to the reporting.
Reproductive development and change begin at the moment of conception and continue throughout life. The sex of an individual is determined at the moment of conception by the chromosome information supplied by the particular ovum and sperm that join to create the new life. At approximately week 5 of intrauterine life, primitive gonadal tissue is already formed. In both sexes, 2 undifferentiated ducts, the mesonephric and paramesonephric ducts, are present. By week 7 or 8, in chromosomal males, early gonadal tissue differentiates into primitive testes and begins formation of testosterone. Puberty is the stage of life at which secondary sex changes begins. These changes are stimulated when the hypothalamus synthesizes and releases gonadotropin-releasing hormones, which in turn triggers the anterior pituitary to begin the release of follicle-stimulating hormones and luteinizing hormones. These hormones initiate the production of androgen and estrogen, which in turn initiate secondary sex characteristics and the visible signs of maturity. For the androgenic hormones are the hormones responsible for muscular development, physical growth, and the increase in sebaceous gland secretions that causes typical acne in both boys and girls. In girls, testosterone influences enlargement of the labia majora, clitoris, and formation of axillary and pubic hair. In the estrogen is responsible for female physical features and reproduction. Men have estrogen too, but in smaller amounts. When triggered at puberty by follicle-stimulating hormones, ovarian follicles in females begins to excrete a high level of the hormone estrogen. The increase in estrogen levels in the female at puberty influences the development of the uterus, fallopian tubes, and vagina, typical female fat distribution, and hair pattern.
Good day, everyone. I'm Christine Nagura, and I will be discussing about the secondary sex characteristics. Secondary sexual characteristics are those sexually dimorphic characteristics that are not directly involved in reproduction. And adolescent sexual development is categorized into stages. There are wide variations in terms of the time na nire-require for adolescents to move to these developmental stages. Although merong wide variations in terms of the time na required, yung sequential order pa rin ay fairly constant, or yung pagkakasunod-sunod sa developmental stages ay pare-pareho lang din. In girls, pubertal changes typically are manifested as growth spurt, increase in the transverse diameter of the pelvis, breast development, growth of pubic hair, onset of menstruation, growth of axillary hair, and vaginal secretions. And the average age at which menarche or the first menstrual period occurs is 12.4 years old, according to McDowell et al. In 2007. It may occur as early as age 9 or as late as age 17. However, and still be within a normal age range. Irregular menstrual periods are the rule rather than the exception for the first year. Menstrual periods do not become regular until ovulation consistently occurs with them, or menstruation is not dependent on the ovulation. This is one reason why estrogen-based oral contraceptives are not commonly recommended until a girl's menstrual periods have become stabilized or are ovulatory, to prevent administering a compound to halt ovulation before it is firmly established. And for males, secondary characteristics includes, in boys, production of spermatozoa does not begin in intrauterine life, or as does the production of ova, nor are spermatozoa produced in a cyclic pattern as are ova. Rather, they are produced in a continuous process. So guys start producing spermatozoa or sperm, in short, at onset of puberty. And boys usually start puberty when they're around 10 or 12 years old, though some start a little sooner and others a little later. And there's also a cool way to tawag sa guy na nag-produce or first produces sperm. The same with menarche, pero dito spermarchy. And lastly, with male naman, secondary sex characteristics of boys usually occur in the order of increase in weight, growth of testes, growth of face, axillary, and pubic hair, voice changes wherein the voice of the boys nagtitipan sila, penile growth, increase in height, spermatogenesis, or the production of sperm.
The male reproductive system consists of both external and internal divisions. I'm Bianca Monique Vire, and I will be discussing about the external structure of the male reproductive system. External genital organs of the male include the testes, scrotum, and penis. So first, the scrotum. The scrotum is a rugated skin-covered muscular pouch suspended from the perineum. Its functions are to support the testes and to help regulate the temperature of sperm. In very cold weather, the scrotal muscle contracts to bring the testes closer to the body. In very hot weather or in the presence of fever, the muscle relaxes, allowing the testes to fall away from the body. In this way, the temperature of the testes can remain as even as possible to promote the production and viability of sperm. So did you know that sperm are sensitive to high temperature? Testicles are located outside of the human body because the ideal temperature for sperm production and thus for male fertility is about 3 to 4 degrees below the ideal human body temperature of 37 degrees Celsius. Next is the testes. The testes are two ovoid glands, 2 to 3 centimeters, that lie in the scrotum. Each testis is encased by a protected wide fibrous capsule and is composed of several lobules, with each lobule containing interstitial cells. So, these are responsible for making testosterone, the primary male sex hormone, and for producing sperm. Within the testes are coiled masses of tubes called seminiferous tubules. These tubules are responsible for producing the sperm cells through a process called spermatogenesis. The penis is composed of 3 cylindrical masses of erectile tissue in the penis shaft, 2 termed the corpus cavernosa, and a third termed the corpus spongiosum. The urethra passes through these layers of erectile tissue, making the penis serve as an outlet for both urinary and reproductive tracts in men. With sexual excitement, nitric oxide is released from the endothelium of blood vessels. This results in dilation of blood vessels and the increase of blood flow to the arteries of the penis. The cavernosus muscle at the base of the penis then contracts, trapping both venous and arterial blood in the 3 sections of erectile tissue, and leading to distension and erection of the penis. The penile artery, a branch of the pudendal artery, provides the blood supply for the penis. Penile erection is stimulated by parasympathetic nerve intervention. At the distal end of the organ is a bulging sensitive ridge of tissue, the glans. A retractable casing of skin, the prepuce, protects the nerve-sensitive glands at birth. Many infants in the United States have their prepuce tissue removed surgically shortly after birth, or as we know it, circumcision.
Thank you, Bianca. So let's proceed to the male internal reproductive organs, or the male internal structures. So the male internal reproductive organs are epididymis, the vas deferens, the seminal vesicles, the ejaculatory ducts, the prostate gland, the urethra, and the bulbourethral glands. So first, let's proceed where these structures are located. So first, we have the seminal vesicles. Seminal vesicles are 2 convoluted pouches that lie along the lower portion of the posterior surface of the bladder and empty into the urethra through the ejaculatory ducts. You can see the illustration through your book. So next we have the ejaculatory ducts. So we have 2 of these. They pass through the prostate gland and join the seminal vesicles to the urethra. Next we have the bulbourethral glands. It's also known as Cooper glands. Lie beside the prostate gland and empty via the short ducts into the urethra. We have the urethra. Urethra is a hollow tube from the base of the bladder after passing through the prostate gland outside through the shaft and the glands of the penis. Next, we have the prostate gland. So the prostate gland is a chestnut-sized gland that lies just below the bladder. Next, we have the vas deferens, also known as the ductus deferens. It's an additional hollow tube surrounded by arteries and veins and protected by thick fibrous coating. As you can see here, the illustration inside of the vas deferens, which composed of arteries and veins. Next, we have the epididymis. Each epididymis is so tightly coiled, its length is extremely deceptive, and is actually over 20 feet long. Some sperm are stored in the epididymis, and a portion of alkaline fluid that will surround sperm at maturity is produced by the cell lining of the epididymis. Okay, let's proceed to the next slide. So now that we have discovered where these male internal structures are located, we will now move on how these structures work. So first off, we have the seminal vesicles. So seminal vesicles are glands that secrete a viscous alkaline liquid which is high in pH level, has a high sugar, protein, and prostaglandin content. Next, we have the 2 ejaculatory ducts. So, as I mentioned earlier, these ducts pass through the prostate gland and join the seminal vesicles to the urethra. Next, we have the 2 bulbourethral glands. Always remember, this is also known as Cooper's gland. Like the prostate gland and seminal vesicles, they also secrete an alkaline fluid that helps to counteract the acid secretion of the urethra and ensure the safe passage of spermatozoa. So do you know that semen is derived from 60% prostate gland, 30% from seminal vesicle, and also 5% from epididymis and 5% from the bulbourethral glands. As you can see on the lower left part of this slide, we have this illustration, which is the figure 5.3 in page 90 in your book. This is the difference between the circumcised and uncircumcised penis. What is the difference between these two besides from the extra foreskin from the uncircumcised penis? So doctors recommend boys or men to have circumcision because circumcision makes it simpler to wash the penis. However, boys with uncircumcised penises can be taught to wash regularly beneath the foreskin to decrease the risk of urinary tract infections. The risk of urinary tract infections in male is low, but these infections are more common in uncircumcised males. So, hindi naman po required for males to undergo circumcision. So, next slide, we have this prostate gland. So, the prostate gland secretes a thin alkaline fluid when added to the secretion from the seminal vesicles and then accompanying sperm from epididymis. This alkaline fluid further protects sperm from being immobilized by naturally low pH level of the urethra. As I mentioned earlier, urethra produces more acidic. While this alkaline fluid has higher pH level, it neutralizes. In middle life, many men develop benign hypertrophy of the phosphate, also known as the benign prostatic hyperplasia or BPH. So this BPH is common condition as men get older. An enlarged prostate gland can cause uncomfortable urinary symptoms such as blocking the flow of urine out of the bladder. It also causes bladder, urinary tract, or kidney problems. This can be treated by transurethral resection of the prostate, and one of the symptoms of this BPH is urinary retention. Keep in mind that BPH or benign hypertrophy of the prostate is different from prostate cancer. This BPH can also interfere both fertility and urination, such as urinary retention, yung hindi po na lalabas lahat na urine from the bladder. So next, we have the vas deferens, also known as ductus deferens. Don't forget that. So it carries sperm from the epididymis through the inguinal canal into the abdominal cavity, where it ends at the seminal vesicles and the ejaculatory ducts. Sperm mature as they passes through the vas deferens. So sa vas deferens, dito po nagmamature ang mga sperm cells. So let's proceed to the epididymis. So as I mentioned earlier, that each epididymis is so tightly coiled that its length is extremely deceptive. This is actually over 20 feet long. So, ganun po kahaba. It is responsible for conducting sperm from the tubule to the vas deferens. It is the next step in the passage to the outside. So, because epididymis is so narrow along its entire length, infection of the epididymis can easily lead to scarring of the lumen. That then prohibits the passage of the sperm beyond the scared point. So sperm are immobile and incapable of fertilization as they passes or are stored on the epididymis level. So it takes at least 12 to 20 days for them to travel the length of the epididymis and a total of 64 days for them to reach the maturity. This is one of the reasons that aspermia or absence of sperm and oligospermia or only having 120 million sperm per milliliter are problems do not appear to respond immediately to therapy but rather only after 2 months. So last, we have the urethra. So always remember, the urethra is approximately 8 inches, 18 to 20 centimeter, and lined with mucous membrane. So the urethra in males is usually longer than females. So mas uncommon for men to have UTI. Thank you. Let's proceed to the female reproductive structure.
So let us continue with the female reproductive system. So the female reproductive system, just like the male reproductive system, has both the external and internal components. So I'm Johanna Rose Benitez, and I will be discussing about the female external structures. So the structures that form the female external genitalia are termed the vulva, from the Latin word for covering. So I have here an illustration that shows the external structures of a female reproductive system. So we have here the mons veneris, the clitoris, the orifice of the urethra, the labia minora, the labia majora, the perineum, the anus, the skin's gland, the vaginal vestibule, the hymen, the orifice of the vagina, the Bartholin's gland, and the fourchette. So we'll be proceeding the first one, which is the mons veneris. So the mons veneris is a pad of an adipose tissue located over the symphysis pubis, or the pubic bone joint. So it is covered by a triangle, of course, and it is the curly hairs. So the purpose of the mons veneris is to protect the junction of the pubic bone from a trauma. Next, let's proceed to the labia minora, which is the posterior to the mons veneris, which spreads two hairless folds of a connective tissue. So before menarche, these folds are fairly small, and by childbearing age, they are firm and full, and after menopause, they atrophy and again become much smaller. So normally, the folds of the labia minora are color pink. The internal surface is covered with a mucous membrane and the external surface with the skin. So this area is abundant with a sebaceous gland. So there are localized sebaceous cysts that may occur in this part. So women who perform monthly vulvar examinations are able to detect the infection and also the other abnormalities present in this part. So we have also here the labia majora, which are the two folds of adipose tissue, which covered by the loose connective tissue and the epithelium that are positioned lateral to the labia minora. So this is covered by a pubic hair, and the labia majora serves as the protection for the external genitalia and the distal urethra and vagina. So they are fused anteriorly but separated posteriorly. So trauma in this area, which occurs from a childbirth, and in other cases with rape, it can lead to extensive edema or the swelling formation because of the looseness of the connective tissue base. So we have here the external organs. We have here the vaginal vestibule. The vestibule is the flattened, smooth surface inside the labia. So the openings of the bladder, the urethra, and the uterus to the vagina both arises from the vestibule. So we have also here the clitoris, which is a small rounded organ of an erectile tissue at the forward junction of the labia minora. So clitoris is approximately 1 to 2 centimeter. It is covered by a fold of skin. It is the prepuce. So the clitoris is a sensitive part to touch and also in temperature. It is also the center of the sexual arousal and orgasm in a woman. So the arterial blood supply for the clitoris is plentiful. So we have also here the skin's gland, which are located just lateral to the urinary meatus, one on each side. So their ducts open onto the urethra. We have also here the Bartholin's gland, which are located just lateral to the vaginal opening on both sides, and their ducts open onto the distal vagina. So both skin's gland and the Bartholin's gland may become infected and produce a discharge or a local pain. So these secretions from both of these glands helps lubricate the external genitalia during coitus. So the alkaline pH of their secretion helps improve the survival of the sperm in the vagina. Next is the furcae. It is the ridge of a tissue formed by the posterior joining of the two labia minora and the labia majora. So this is a structure in which it is sometimes cut during a childbirth to enlarge the vaginal opening. So the posterior to the furcae is the perineal muscle or the perineal body. So this is a muscular area in which it is easily stretched during a childbirth, and it allows the enlargement of the vagina and the passage of the fetal head. So many exercises suggested for pregnancy are aimed to make the perineal muscle more flexible, and that allows the easier expansion during the birth without tearing this tissue. So next is the hymen. Hymen is a tough but elastic semicircle of tissue that covers the opening of the vagina in childhood. It is often torn during the time of the first sexual intercourse. However, because of the use of the tampons and active sports participation, many girls who have not had sexual relations do not have intact hymens, and at this time of their first pelvic examination. And occasionally, a girl has an imperforate hymen, or the hymen is so complete that it does not allow for passage of the menstrual blood from the vagina or for sexual relations until it is surgically incised. So we have also here, the side is the vulvar blood supply, which is the blood supply of a external genitalia. It is mainly from the pudendal artery and a portion of the inferior rectus artery. So the venous return is through the pudendal vein. So the pressure on this vein by the fetal head can cause extensive back pressure and development of the varicosites or the distended veins in the labia majora. So because of the rich blood supply, trauma to this area occurs from pressure during the childbirth. This causes the large hematomas. So this is the vulvar blood supply. So next we have the vulvar nerve supply. So this is the anterior portion of the vulva that derives its nerve supply from the elonginal and genitofemoral nerves, which is the L1 level, and the posterior portions of the vulva and vagina are supplied by the pudendal nerve S3 level. The rich nerve supply makes the area extremely sensitive to touch, pressure, pain, and also in temperature. As summary again, in this part, we have the female reproductive structures that focuses on the external components.
Good day to all of you. My name po is Mary P. Perillo, and I will be discussing the female internal reproductive structures. There are namely 4 organs included, which are the ovaries, fallopian tubes, uterus, and the vagina. I will first be discussing the ovaries. The ovaries are approximately 4 centimeters long and 2 centimeters in diameter. It is 1.5 centimeters thick. The ovaries take the shape and size of an almond. Looking at the picture here po, they take a grayish-white color and appear to have indentations on its surface. The ovaries can be located on both sides of the uterus, in the lower abdomen. Its main function is to produce, mature, and discharge ova or the egg cells. Through the process po, the ovaries produce estrogen and progesterone that initiate and help in regulating menstrual cycles. Ovarian maturation is necessary for maturation and maintenance of secondary sex characteristics. The ovaries have 3 principal divisions. The first one is the protective layer of surface epithelium. The second one is the cortex. This is where the primordial oocytes mature into ova, and large amounts of estrogen and progesterone are produced. The third one po is the central medulla. This is where the nerves, blood vessels, etc. po are contained. So with the With the division of reproductive cells or the gametes, the oocytes, like the sperm, are special body cells that have the necessary components in creating life. Like we have previously learned from our high school years to the present, we know that these cells undergo mitosis and meiosis until a required number of autosomes and chromosomes are acquired. So during fertilization po, these cells would have created an individual with the combined autosomes and chromosomes resulting to normal numbers of 46 chromosomes. With maturation of oocytes, each oocyte lies in a primordial follicle. The 5 to 7 million of ova formed from the intrauterine state is constantly reduced as women age, so that by the time menopause comes, there are no more ova left. Next is the fallopian tubes. The fallopian tubes arise from each upper corner of the uterine body and extend outward and backward until each opens at its distal end, next to an ovary. Its function is to convey the ovum from the ovaries to the uterus and to provide a place for fertilization of the ovum by sperm. The fallopian tube is divided into 4 separate parts. The first one po is the interstitial portion. It is the most proximal division. It has a length of about 1 centimeter. The second one is the isthmus. It is approximately 2 centimeters in length and is extremely narrow. This is the portion where tubal ligation or tubal sterilization is done. The third one po is the ampulla. It is the longest portion with a length of about 5 centimeters. This is where the ovum and the sperm meet for fertilization. The last po is the infundibular portion, being the most distal segment. It is 2 centimeters long and is funnel-shaped. So the third organ po is the uterus. The uterus is a hollow muscular pear-shaped organ located in the lower pelvis. Its function is to receive ovum from the fallopian tubes, provide a place for implantation and nourishment, and expel the fetus after its maturity. The uterus is approximately 5 to 7 centimeters long, 5 centimeters wide in its widest part, 2.5 centimeters deep, and weighs about 60 grams. The uterus consists of 3 divisions. The first one is the body or the corpus. It is the uppermost part and it forms the bulk of the organ. This part po can easily expand to the size of the growing fetus during pregnancy. The second one is the isthmus. It is the short segment between the body and the cervix. During pregnancy, this portion greatly enlarges to accommodate the growing fetus. And the last po is the cervix. It's approximately 2 to 5 centimeters long and represents 1/3 of the total uterus size. Uterine and cervical coats. The uterine wall consists of 3 separate layers. The first one is the inner mucous membrane or the endometrium. This layer po plays a key role in the menstrual function as this layer responds to hormones. It grows a thick, blood vessel-rich, glandular tissue in preparation for pregnancy. If not pregnant po, this is the layer that sheds blood during menstruation. The middle, the muscle fibers or the myometrium, this is also known as the muscle layer of the uterus. It has a function po of constricting the tubal junctions and prevention of regurgitation of menstrual blood into the tubes. This layer po holds the internal cervical layer close to prevent preterm pregnancies and helps po in limiting blood loss during childbirth by constricting blood vessels. The outermost layer po is the perimetrium, where it serves a purpose of adding strength and support. Uterine blood supply. The large descending abdominal aorta divides to form 2 iliac arteries. Main division of the iliac arteries are the hypogastric arteries. This divide to form the uterine arteries that supply the uterus. Uterine nerve supply. The uterus is supplied by both the efferent or motor and afferent or the sensory nerves. Uterine support. The uterus is suspended in the pelvic cavity by several ligaments that also help support the bladder and is further supported by a combination of fascia and muscle. The uterus po is not a fixed organ, so it is free to enlarge without discomfort during pregnancy. But po, if these ligaments are overstretched, it may not support the bladder well after the pregnancy. This would lead po to conditions such as the cystocele, which is where the bladder can herniate into the interior of the vagina, or the rectocele, where the rectum has pouch into the vaginal wall. Or there may be several uterine deviations. First po is the anteverted or anteversion, where the entire uterus po is tipped forward. Retroverted or retroversion is the condition in which the entire uterus po is tipped backward. Anteflexion, the condition in which the uterus is bent sharply forward at the junction with the cervix. And last po is the retroflexion, where the body is bent sharply back just above the cervix. So next po, we have the vagina. It is a hollow musculomembranous canal located posterior to the bladder and anterior to the rectum. Its function is to act as the organ of intercourse and to convey sperm to the cervix. It expands to serve as a birth canal during childbirth. At the cervical end of the structure, the presence of fornices can be observed on all sides of the cervix. These fornices po are namely the posterior, anterior, and the lateral fornices. The mucus produced by the vaginal lining has a rich glycogen content that makes the vagina acidic. So po, since the vagina is an organ that comes in contact with the external surface, it is frequented by bacteria. So when said bacteria po comes in contact with the mucus, lactic acid is formed, which makes the usual pH of the vagina acidic. This reaction po helps in protecting the area from bacterial infections. And I will also be po discussing the breasts. Mammary glands or breasts are formed from the ectodermic tissue early in the utero. The growth of the breasts po is usually halted until puberty. Development of the breasts is triggered with the rise of estrogen levels during the pubertal stage. Milk glands of the breasts are divided by connective tissue partitions into approximately 20 lobes. The nipple is composed of smooth muscle that is capable of erection or sucking stimulation. The nipple also has 20 small openings where milk is secreted po. Thoracic branches of axillary, internal mammary, and intercostal arteries carry a profuse amount of blood supply to the breast. So the effective blood supply in the breast po is essential in bringing nutrients to the milk glands that helps in a plentiful supply in breastfeeding. So that would be all for my part po. Thank you po so much for listening.
So menstruation. Menstrual cycle or a female reproductive cycle is episodic uterine bleeding in response to cyclic hormonal changes. The purpose of menstruational cycle is to bring an ovum to maturity and renew a uterine tissue bed that will be responsible for the ova's growth should it be fertilized. It is a process that allows for conception and implantation of a new life. It is poor introduction to sexuality and womanhood for a girl to begin menstruation unwarned and unprepared for the important internal functions it represents. So the length of the menstrual cycle differs from woman to woman, but the average length is 28 days from the beginning of one menstrual flow to the beginning of the next. It is not unusual for cycles to be as short as 23 days or as long as 35 days. The length of the average menstrual flow is 4 to 6 days, although women may have periods as short as 2 days or as long as 7 days. So, 4 body structures are involved in the physiology of the menstrual cycle, which are the hypothalamus, the pituitary gland, and the ovaries and the uterus. For a menstrual cycle to be complete, all 4 structures must contribute their part. Inactivity of any part results in an incomplete or ineffective cycle. And here you can see a figure of the interaction of pituitary, uterine, ovarian functions in a menstrual cycle. So hypothalamus. The release of GnRH, also called luteinizing hormone releasing hormone or LHRH, by the hypothalamus initiates the menstrual cycle. When the level of estrogen rises, the release of hormone is repressed, and menstrual cycles do not occur. Beginning with puberty, the hypothalamus becomes less sensitive to estrogen feedback. This results in the initiation every month in females of the hormone GnRH. GnRH is transmitted from the hypothalamus to the anterior pituitary gland and signals the gland to begin producing gonadotrophic hormones FSH and LH. Because production of GnRH is cyclic, the menstruation periods are also cyclic. Disease of the hypothalamus that cause deficiency of this releasing factor can result in delayed puberty. So, in pituitary gland, under the influence of GnRH, the anterior lobe of the pituitary gland produces two hormones that act on the ovaries to further influence the menstrual cycle. FSH, a hormone that is active early in the cycle and is responsible for maturation and the ovum, and LH, a hormone that becomes most active in the midpoint of the cycle and is responsible for ovulation. The release of the mature egg cell from the ovary and growth of the uterine lining during the second half of menstrual cycle. So, in ovary, FSH and LH are called gonadotrophic hormones because they cause growth in gonads. Every month during the fertile period of a woman's life, from menarche to menopause, one of the ovary's primordial follicles is activated by FSH to begin to grow and mature. 4 phases of menstrual cycle. The first phase of menstrual cycle is proliferative. Immediately after a menstrual flow, the endometrium or lining of the uterus is very thin, approximately 1 cell layer in depth. As the ovary begins to produce estrogen in follicular fluid under the direction of pituitary FSH, the endometrium begins to proliferate. This growth is very rapid and increases the thickness of endometrium approximately 8-fold. The second phase of menstrual cycle is secretory. After ovulation, the formation of progesterone in the corpus luteum causes the glands of uterine endometrium to become twisted in appearance and dilated with quantities of glycogen and bacon. The capillaries of the endometrium increases in amount until the lining takes on the appearance of rich, spongy velvet. This second phase of the menstrual cycle is termed the progestational, luteal, premenstrual, or secretory phase. So we have here the third phase, which is chemic. If the fertilization do not occur, the corpus luteum in the ovary begins to regress after 8 to 10 days. As it regresses, the production of progesterone and estrogen decreases. With the withdrawal of progesterone stimulation, the endometrium of the uterus begins to degenerate. The capillaries rupture and 1-minute hemorrhages, and the endometrium slows off. And the last phase, the fourth phase, is the menses. Menses, or the menstrual flow, is composed of blood from the ruptured capillaries, mucin from the glands, fragments of endometrial tissue, the microscopic, atrophied, and unfertilized ovum. Menses is actually the end of arbitrarily defined menstrual cycle because it is the only external marker of the cycle. However, the first day of menstrual flow is used to mark the beginning day of a new menstrual cycle. So the next we have here is cervix. The mucus of the uterine cervix as well as the uterine body changes each month during the menstrual cycle. Women can analyze cervical mucus changes to help plan coaches to coincide with ovulation if they want to increase their chance of becoming pregnant, or plan to avoid coat use at the time of ovulating to prevent pregnancy. So we have here 2 tests in the cervix, which is the Fern test and the Spin-Burkitt test. When high levels of estrogen are present in the body, this is for the Fern test. As they are just before ovulation, the cervical mucus forms fern-like pattern caused by crystallization of sodium chloride on mucus fibers when it is placed on a glass slide and allowed to dry. Cervical mucus can be mixed at mid-cycle to detect whether ferning, which suggests a high estrogen surge, is present. Women do not ovulate, continue to show the fern pattern throughout the menstrual cycle, or they never demonstrate it because their estrogen level never rises. Other one is the Spin-Burkitt test. Performing this test at the midpoint of a menstrual cycle is another way to demonstrate that high levels of estrogen are being produced and by implication that ovulation is about to occur. A woman can do this by stretching a mucus sample between thumb and finger, or it can be tested in examining room by smearing a cervical mucus specimen on a slide and stretching the mucus between the slide and cover slip.
we have now the education for menstruation. So education about menstruation is an important component of comprehensive sexuality education. Many myths about menstruation still exist. Early preparation for menstruation to dispel these myths is important to a girl's concept of herself as a woman because it teaches her to trust her body, to think menstruation as a mark of pride or growing up rather than a burden. Education regarding menstruation is equally important for boys so they can appreciate the cyclic progress that a woman's reproductive system activates and can be active participants in helping plan or prevent conception. Girls who are well prepared for menstruation and view it as a positive happening are more likely to cope with any menstrual discomfort effectively, which results to fewer missed school days than those who view menstruation as an ill. And lastly, we have here the menopause. Menopause is the cessation of menstrual cycles. Premenopausal is a term to denote the period during which menopausal changes occur. Postmenopausal describes the time of life following the final menses. The age range at which menopause occurs is wide, between approximately 40 and 55 years of age with a mean age of 51. The age at which menopause symptoms begin to appear to be genetically influenced or at least not associated with age of menarche. Menopause can cause psychological stress as ovaries are women's chief source of estrogen. When ovaries begin to atrophy, reducing estrogen production, hot flashes, vaginal dryness, or osteoporosis occurs. Urinary incontinence from lack of bladder support can also occur. If a woman lives to be 80, she will spend a third of her life postmenopausal. And that is all for my report in menstruation.
Good day everyone, this is Chloe Lynn Francisco, and today I will be discussing about sexuality and sexual identity. But first, let us understand the difference between the two. Sexuality is a multidimensional phenomenon that includes feelings, attitudes, and actions. It has both biologic and cultural components. It also encompasses and gives direction to a person's physical, emotional, social, and intellectual responses throughout life. Biologic gender is the term used to denote a person's chromosomal sex, such as for male we have the XY chromosomes, and the female we have the XX chromosome. Gender identity or sexual identity is the inner sense a person has of being male or female, which may be the same as or different from the biologic gender. Gender role is the male or female behavior person exhibits, which again may or may not be the same as biologic gender or gender identity. Now let us move on to the development of gender identity. Several theories exist regarding whether gender identity arises from primarily a biologic or a psychosocial focus. The amount of testosterone secreted in utero, or a process termed sex typing, may affect how gender develops. How appealing parents or other adult role models portray their gender roles may also influence how a child envisions himself or herself. Gender role is also culturally influenced. In Western society, women have in the past have been viewed as having intrinsic nurturing qualities with sole responsibility for child rearing and homemaking. Men were viewed as financial providers. But today, gender roles are more interchangeable, where women pursue all types of jobs and careers without loss of femininity, and men participate in child rearing and household duties without loss of masculinity. Now, this particular individual sense of gender identity develops throughout an entire lifespan, but the stage is set by expectation even before a child is born. Now, although parents usually respond to the question, do you want your baby to be a boy or a girl, with the answer, it doesn't matter. As long as the baby is healthy, many parents actually do have a strong preference or preferences whether they want a female or a male child. Now, let us move on to the following stages where gender identity develops. First, we have infancy. From the day of birth, female and male babies are treated differently by their parents. People generally bring girls dainty rattles and dresses with ruffles. On the whole, they are treated more gently by parents and held and rocked more than male babies. People tend to buy boys bigger rattles and sports-related jogging suits. Also, admonitions given babies can be different. A girl might be told, "Don't cry, you don't look pretty when you cry." And a boy might be told, "You should learn to look tougher in this world." And by the end of the first year, these particular differences in play are usually strongly evident. Boys demonstrate more innate aggressions even at this early stage than do girls. Next, we have preschool period. Now, at this stage, by the age 3 or 4 years, they can already say what sex they are, and they have absorbed cultural expectations of that sex role. Often, boys will play rough and tumble games with other boys, and girls will play more quietly, although the two frequently mix at this stage. Next, we have school-age child. Early school-age children typically spend playtime imitating adult roles as a way of learning gender roles. Where once schools promoted differences between males and females by separating activities into those only for girls and those only for boys. Promoting beliefs such as expecting boys to be poorer readers, to write less neatly, and to act rougher in the school hallways. Grade schools have now become more attuned to unisex activities. Girls may participate in activities that were once male-dominated, such as Little League and auto repair courses. Same as to our boys, wherein they can now take cooking or ballet lessons, formerly the province of girls. Next, we have adolescent. Now, at this particular stage, some adolescents choose a child of their own gender, a few years older than themselves, to use as their model of gender role behavior. This is their way of understanding and making themselves feel comfortable with their own sex before they reach out and interact with members of the opposite sex. Moreover, at this stage, adolescence can be a very stressful time for a boy who first realizes that he is gay, or a girl who first realizes that she is a lesbian. This is part of the reason for the high suicide rate in adolescence, maybe because homosexual teenagers feel so lost in a heterosexual dominant culture that we live in today. Next, we have young adult. Now, during this time, they choose the way they will express their sexuality along with other life patterns. Many young adults marry with a commitment to one sexual partner. Others establish relationships or cohabitation that are less binding by legal definitions, but perhaps equally binding in concern and support. Young adults may view cohabitation as a means of learning more about a possible marriage partner on a day-to-day basis, in the hope that a future marriage will then be stronger and more lasting. Homosexuality or bisexuality may be overly expressed for the first time during this period. Next, we have middle-aged adult. Now, at this stage, for many women and men in midlife, sexuality has achieved a degree of stability. A sense of masculinity or femininity and comfortable patterns of behavior have been established. This increased security and identity can now promote greater intimacy in sexual and social relationships. This may also be a time when adults allow themselves more freedom in exploring and satisfying sexual needs. And next, we have older adult. Now, at this stage, both male and female older adults continue to enjoy active sexual relationships. Some men may experience less erectile firmness or ejaculatory force than when they were younger, but others can discover that they are able to maintain an erection longer. Older women may have less vaginal secretions because they have less estrogen after menopause. Use of water-soluble lubricant before coitus can enhance their comfort and enjoyment. Moreover, both sexes still need to follow safer sex practice throughout life. Because males remain fertile throughout life, this means that they must continue to be responsible sex partners in terms of reproductive planning. Now, since we are done discussing about the different stages of development in sexual identity, we now move on to another factor or aspect that also affects one's sexual identity, and that is if an individual is physically challenged. Now, same as others, individuals who are physically challenged have sexual desires and needs. However, they may have difficulty with sexual identity or sexual fulfillment because of their condition. In all instances in which one sexual partner is disabled in some way, the response of a loving partner does much to enhance body image and feelings of adequacy of a mate. Encouraging these clients to ask questions and work on specific difficulties is part or is also our nursing role. Now that sums up my topic. Let us now lend our ears to the next reporter.
Now, Ali and I will be talking about the nursing process for promotion of reproductive and sexual health. First, an overview. Problems of sexuality or reproductive health may not be evident on first meeting a client because it may be difficult for a person to bring up the topic until he or she feels more secure. This makes good follow-through and planning important because a person may find the courage to discuss a problem once but then be unable to do so again. If the problem is ignored or forgotten through a change in caregivers, it may never be addressed again. Assessing sexuality may not be appropriate as a routine part of every health assessment, however, it should be included when appropriate, such as when discussing adolescent development or before providing reproductive life planning information during pregnancy and after childbirth. Assessment in the area of reproductive health begins with interviewing to determine what the client knows about the reproductive process and STIs. Any concerns they might have about their own reproductive functioning or safer sex practices should be explored. It's important to include in a physical examination observation for normal distribution of body hair, such as triangle-shaped pubic hair in women and diamond-shaped pubic hair in men, for normal genital and breast development, and for signs and symptoms of STIs. Many STIs are asymptomatic, so it's important to assess whether the client is at risk for contracting an STI. Examples of specific questions to include in a sexual history are if they're sexually active, is their sexual partner of the same or different gender, how many sexual partners they've had in the past 6 months, do they practice safer sex, and are they using a method to prevent pregnancy or STIs.
Nursing diagnosis for promotion of reproductive and sexual health. So these are the common nursing diagnoses used in regards to reproductive health include health-seeking behaviors related to reproductive functioning, anxiety related to inability to conceive after 6 months without birth control, pain related to uterine cramping from menstruation, disturbance in body image related to early development of secondary sex characteristics, outcome identification and planning for promotion of reproductive and sexual health. A major part of nursing care in this area is to empower clients to feel control over their bodies. Plan health teaching to provide clients with knowledge about their reproductive system and specific information about ways to alleviate discomfort or prevent reproductive diseases. It may also be important to plan intervention to strengthen the person's gender identity or role behavior. It is essential to design care that demonstrates acceptance of all gender-related lifestyles equally. Implementation for promotion of reproductive and sexual health. A primary nursing role concerning reproductive anatomy and physiology is education. This is a major role because both female and male clients may feel more comfortable asking questions of nurses than of the other healthcare providers. To help clients understand reproductive functioning and sexual health throughout their life, a specific question might include the following: encouraging women over 40 to have mammograms, explaining to a school-age boy that nocturnal emissions are normal, teaching an early adolescent what is normal and abnormal in relation to menstrual function, teaching a young adolescent safer sex practices, explaining reproductive physiology to a couple who wish to become pregnant.
Evaluation in the area of reproductive health must be ongoing because health education needs change with circumstances and increased maturity. For example, the needs of a woman at the beginning of a pregnancy may be totally different from her needs at the end. How people feel about themselves sexually may have a great deal to do with how quickly they recover from an illness, how quickly they are ready to begin self-care after childbirth, or even how well motivated they are as adolescents to accomplish activities in other life phases that depend on being sure of sexuality or gender role. Let's take a look at this example. Suzanne and Kevin Matthews are a young adult couple who are 6 months pregnant and is coming for a routine visit. Suzanne is distressed and states that her husband isn't interested in her anymore because they haven't had sex since she became pregnant. In response, Kevin states that he's afraid he'll hurt the baby. Prior to this pregnancy, the couple engaged in coitus 2 to 3 times per week. It's important to note that following a pregnancy, many women experience increased sexual interest because the new growth of blood vessels during pregnancy lasts for some time and continues to facilitate pelvic vasocongestion. This is why discussing sexual relationships is an important part of health teaching during pregnancy. At a time when a woman might want sexual contact very much, couples need to be free of myths and misconceptions, such as the notion that orgasms will cause a spontaneous miscarriage. For activities of daily living, a nurse should be able to assess the couple's lifestyle and sexual concerns. We can encourage the couple to continue routine prenatal care and discuss alternative sexual activities like cuddling or massage at each visit. This is because as pregnancy progresses, discomfort, fatigue, and increasing abdominal size and pressure may interfere with a satisfying sexual relationship. Advanced planning can prepare the couple for any adaptations that may be necessary. The expected outcome would be that the couple continues prenatal care and describes other ways of sexual expression. For consultations, a nurse should be able to assess signs and symptoms of pregnancy as well as note any indications of complications. We can consult with a team primary care provider to be certain that the client has no contraindications to remaining sexually active during pregnancy. This is because in a few women who have had previous miscarriages or if vaginal bleeding is present, sexual relations may be contraindicated or the pregnancy will be threatened. The expected outcome will then be that the couple's primary care provider will supply information on the ability of the couple to remain sexually active throughout the pregnancy. With regards to procedures or medications, the nurse should be able to assess whether alternative types of sexual activity would fulfill the couple's needs. We can review alternative sexual positions for their optimal comfort and pleasure. This is because alternative sexual positions may be necessary to provide comfort late in pregnancy as the woman's abdomen expands. The expected outcome would be that the couple describes alternative positions or ways they relate to each other. For patient or family education, a nurse in consultation with a physician should be able to assess what the couple understands about reproductive anatomy and usual sexual response. We explain that sexual relations are allowed during pregnancy until labor begins, and we can use charts and illustrations to show how the fetus is protected in utero. This is to emphasize that barring complications, couples can engage in coitus to the extent that is comfortable and desired. The expected outcome is that the couple states that they understand the sexual relations are allowed during a normal pregnancy and they understand that minimal contractions may occur with orgasms, but that these are not harmful unless the woman has a history of premature labor. For spiritual, psychosocial, or emotional needs, a nurse should be able to assess whether the couple knows that hormones can change sexual desire during pregnancy. We can encourage the couple to openly talk about their feelings, concerns, desires, and changes in interest to each other throughout the pregnancy. It's important to highlight that physical and psychological changes occur in both the pregnant woman and her partner throughout pregnancy, and that open communication is essential to enhance the relationship. The expected outcome will be that the couple reports that they are able to voice their feelings and concerns during the pregnancy. A nurse should be able to assess what communication pattern the couple uses to share information with each other. We can teach the importance for a couple to maintain communication. This is because beginning a sound communication pattern during pregnancy can lay a foundation for a sound future relationship. The expected outcome would be that the couple reports that they appreciate the importance of good communication for their ongoing relationship. When it comes to discharge planning, a nurse should be able to assess whether the couple's questions and concerns were answered satisfactorily. We should review concerns about sexual relations at each visit because continued interest in a couple's problems allows them to continue to voice their concerns. The expected outcome is that we document in short the questions that were asked and answered during the continuing visit.
The barrier methods for contraception. First is the diaphragm. The diaphragm is a circular rubber disc that is placed over the cervix before intercourse. Next is the male condom. Male condom is a latex rubber or synthetic sheet that is placed over the erect penis before coitus to trap sperm. Next is the cervical cup. A cervical cup is yet another barrier method of contraception. Cups are made of soft rubber, are shaped like a thimble with a thin rim, and fit snugly over the uterine cervix. Last is the female condom. Condoms for females are latex sheets made of polyurethane and pre-lubricated with a spermicide. The female condom are more expensive than male condom. Surgical methods of reproductive life planning. So the surgical method of reproductive life planning is often called sterilization. So the first surgical method is the vasectomy. In a vasectomy, a small incision or puncture wound is made on each side of the scrotum. Next is the tubal ligation. Sterilization of women could include removal of the uterus or ovaries, but it usually referred to a minor surgical procedure such as tubal ligation, wherein the fallopian tubes are occluded by cautery, crushing, clumping, or blocking, thereby preventing passage of both sperm and ova. The most common operation to achieve tubal ligation is through laparoscopy. So the effect of sexual enjoyment, both tubal ligation and vasectomy may lead to increased sexual enjoyment because they largely eliminate the possibility of pregnancy. Elective termination of pregnancy, or what we call the induced abortion. An elective termination of pregnancy is a procedure performed to end a pregnancy before fetal viability. Such procedures are also referred to as therapeutic, medical, or induced abortion. Next is the medically induced termination. Mifepristone, a progesterone antagonist, is a compound that blocks the effect of progesterone, preventing implantation of the fertilized ovum and therefore causing abortion. So now let's move on to the surgical elective termination procedures. So the following are the surgical elective termination procedures. So first is the menstrual extraction. Menstrual extraction or suction evacuation is the simplest type of surgical termination procedure. It is performed on an ambulatory basis 5 to 7 weeks after the last menstrual period. Menstrual extraction is completed quickly and with a minimum of discomfort. Some abdominal cramping may occur as the tenaculum grasps the cervix or as the loss of the endometrium is suctioned away. So next is the dilatation and curettage. If the gestational age of a pregnancy is less than 13 weeks, a D&C procedure may be used. This procedure is usually done in an ambulatory setting using a paracervical anesthetic block. A D&C has the potential risk of uterine perforation from the instruments used and carries an increased risk of uterine infection. Another surgical elective termination procedure is the dilatation and vacuum extraction. Most second trimester termination, those between 12 and 16 weeks, are done by dilatation and vacuum extraction, which can be either an inpatient or ambulatory procedure. And because of the rigid cannula is used for this procedure, it has a potential for uterine perforation, although this is rare because the cervix was dilated. There is a potential, as in all surgical termination procedure, for post-procedure infection. Next is the prostaglandin or saline induction. Prostaglandin or saline induction is used if a pregnancy is between 16 and 24 weeks, and it is done on an inpatient or ambulatory basis. Next is the hysterotomy. If the gestational age for a pregnancy is more than 16 to 18 weeks, a hysterotomy or removal of the fetus by surgical intervention, similar to a cesarean birth, may be performed. Surgery is necessary at this point, so another surgical elective termination procedure is the partial birth abortion. Partial birth abortion was a surgical technique formerly used during the last 3 months of pregnancy if the fetus was discovered to have a congenital anomaly that would be incompatible with a life or would result in a severely compromised child, such as encephalopathy or high spinal meningocele. Labor was induced by a combination of oxytocin and cervical ripening. The fetus was turned so that the breech presented to the birth canal. As you can see in the picture, a clamp was then inserted into the base of the fetal skull and then the head contents were destroyed. The head was then collapsed and destroyed. Partial birth abortion is no longer legal in the United States. A cesarean birth or vaginal birth of the infant is scheduled instead.
So we come now to the end of the slide. Here is our reference to complete this reporting with the topic of nursing role in reproductive and sexual health. Thank you everyone for listening actively, and we hope that you have acquired new knowledge from us. Let's proceed to the open forum. Yay!